Hello and welcome to this special Lupus Forum webinar on the treatment of SLE. My name's Ed Vital. I'm a Professor of Translational Medicine at the University of Leeds, and I'd first like to introduce our faculty that we have with you today. I'm very happy to be joined by Professor Cynthia Aranow, who's Director of the Clinical Autoimmunity Center of Excellence at the Feinstein Institute for Medical Research in New York, USA, and Professor Richard Furie, who's the Chief of the Division of Rheumatology at the Department of Medicine at Northwell Health, New York, USA. So just a couple of brief housekeeping points. The attendees are going to be on mute for the duration of this meeting, but we definitely want to hear your questions. So you can make those questions at any time through the Q&A function that you should see on your screen as it's illustrated right there. So these are the learning objectives for this webinar. We're going to discuss the latest advances in the immunopathology of lupus, and that's to give you a background into some of the new pathways that would make sense for future treatment. We're also going to be giving you an update on the key therapeutic targets, which will include current and emerging therapies. We're also going to be looking at the challenges of doing the clinical trials that we need to evaluate all of these new exciting new therapies and what the outcome measures of those trials mean and how they relate to our clinical practice. And we'll be looking at the challenge of maintaining consistency in the application of these disease measures across various patient groups. So I'll first be passing over to Cynthia Aranow, who'll be covering the first of those topics. Then it'll be back to myself to talk about the advances in treatment and the different treatment strategies. And I'll pass over to Richard Furie to talk about the challenges involved in conducting these clinical trials. We're going to save all of the questions till the end after you've heard all of those three presentations. But as I say, you can enter them at any time you want, and we'll try and get through as many of them as we can when we get to the Q&A session. So that's enough introduction, and it's time for me to hand over to our first speaker. Welcome, Cindy.
So thank you for the introduction, and it's really quite exciting that we are holding this, and really quite timely that we're holding this special session. So my charge is to discuss the new and emerging pathways in the treatment of SLE. And what I'm going to focus on are the review of some of the immunologic abnormalities that we see in lupus, as these are potential therapeutic targets. Here are my disclosures. So before delving into some of the basic and translational science, I'd like to remind us all of the good news that we're doing better, patients are living longer, in part because of the advances that we've made in therapy. So these are graphs of survival curves from different decades. And on the left, you see that in the 1950s, that a patient with lupus had a 50% chance of surviving 4 years, and that survival did improve over the next 2 decades. On the right are survival curves in the late 70s and 80s, the 90s, the early 2000s, and then the later 2000 aughts. And it's important to see, if you're going to compare the two slides, that the scales are different. But you can absolutely see that improvement of survival has occurred over the last 50, 70 years. So this cartoon is a very old and simplified version depicting the process of antibody production, starting with the processing of an antigen, the yellow blob here, by an antigen-presenting cell, and then the cellular interactions resulting in the production of autoantibodies by B cells. And there are multiple players in the pathophysiology of SLE, including B and T cells, antibodies, immune complexes, cytokines, each of which can contribute to organ damage, and each of which are could be potential targets of therapies. However, these components all represent the process of an adaptive immune response. But we also know that the immune response is composed of two systems, the innate and adaptive, and the acquired immunity, and that abnormalities in both contribute to the pathophysiology of lupus. So the innate immune response is immediate and rapid. It's ancient, evolutionarily primitive, and genetically coded, and it's our first-line defense against foreign invaders. But it's nonspecific, and in addition to the physical barriers such as skin, its cellular components include macrophages, neutrophils, NK cells, and dendritic cells. Importantly, complement falls under the realm of the innate immune system. The innate immune system triggers adaptive immunity, which mounts an immune response more slowly, but this response has antigenic specificity, and there is memory within this immune response, and subsequent exposure to an antigen will result in a not only faster, but a more specific immunologic response. So the adaptive system can be characterized by being cellularly mediated, typically by T cells, although we now know that B cells also have importance, and humourally mediated by antibody. So we all know and recognize that lupus is an autoimmune disease characterized by the production of autoantibodies, antibodies against cells. We also know from the elegant studies done by Arbuckle earlier this century that patients with lupus have a preclinical asymptomatic phase, which may last for almost a decade, in which autoantibodies are present, but that there are no clinical symptoms, and that additional autoantibodies with increased specificity for lupus become prevalent closer to the actual diagnosis of lupus. So lupus is characterized by autoantibodies produced by autoantibody producing autoreactive B cells. So there are abnormalities, including toll-like receptors interacting with nucleic acids, DNA, and RNA, which may lead to extrafollicular activation of autoimmune B cells. As in a protective immune response, B cells mature and differentiate into plasma cells. However, in lupus, autoreactive plasma cells produce autoantibodies, which contribute to organ and cellular damage and dysfunction in several mechanisms, including directly binding to cell surfaces, resulting in apoptotic cell death, or alteration of cell function and or cytokine production by formation of immune complexes and deposition of the immune complexes in tissue, and by activating complement and neutrophils. In addition to being B cell factories, B cells can also serve as antigen-presenting cells and can activate T cells, and thereby creating a loop where these cell types activate each other and amplify the autoimmune response. So this feature suggests an additional mechanism why antibodies targeting and depleting B cells are effective. But additionally, we have antibodies that are not B cell directly depleting, but they target BAFF, such as belimumab, or BAFF receptors. So BAFF is a B cell activating factor. It's a B cell surviving factor, which facilitates the maturation of autoreactive B cells. So targeting this pathway results in minimal B cell depletion, but in a reduction of mature autoreactive B cells. So lupus is also associated with numerous T cell abnormalities, resulting in an abnormal T cell phenotype. T cells in lupus display a distorted gene expression, which results in production of inflammatory cytokines. And compared to healthy controls, production of IL-2 by lupus T cells is reduced. And this is important as IL-2 is a cytokine that's crucial for function and proliferation of T regulatory cells. T cells in lupus also provide excessive help to autoreactive B cells. So T-dependent activation of B cells not only requires that the T cell receptor interact with the B cell MHC and antigen, but it also requires other second interactions, including CD40 and CD40 ligand, which you're going to be hearing much more about from Professor Vital. So these result in antibody or in SLE, autoantibody production. So it's clear that CD4 T cell subsets are skewed in lupus. We've known for some time that Th1 pro-inflammatory cytokines are increased, while Th2 anti-inflammatory cytokines are decreased. We've also known that the balance between pro-inflammatory Th17 cells and Treg cells is tilted towards Th17. Additionally, both T follicular helper cells and T peripheral helper cells are increased, while T follicular regulatory cells, which inhibit B cell activation by T follicular helper cells, are depressed. So there are numerous other cells that have and cellular subsets that have been identified over the years. So the role of interferon alpha in the pathogenesis and pathophysiology of lupus is now well recognized. Interferon is a bridge between the innate and adaptive responses. It regulates the innate and is a trigger for the adaptive. Interferon alpha is produced primarily in plasmacytoid dendritic cells, which, so to speak, make buckets of the cytokine. And its sustained production is thought to be in part due to the continuous stimulation by endogenous nucleic acids, DNA and RNA. Upregulation of interferon-regulated genes has been demonstrated within organs, including skin and kidneys, strongly implicating its pathogenic role of interferon in the initiation and the establishment of the cytokine in lupus. And just to note that the type 1 interferon family actually is composed of 13 subtypes of interferon, including alpha, beta, omega, kappa, and epsilon. But importantly, all subtypes bind to the same interferon receptor. So in terms of interferon and lupus pathogenesis, about half of lupus patients have high circulating levels of interferon alpha and or the interferon signature, which refers to the overexpression of interferon-regulated disease. We know that levels of interferon correlate with disease severity and activity. And interestingly, when comparing interferon high and interferon low patient subsets, in addition to the interferon, there are differences in other cytokines that can be seen both in the resting state and when cells are taken ex vivo and are stimulated, suggesting that there are inherent differences between the interferon high and interferon low groups, which likely has implications regarding potential flares following infections, as well as responses to therapy. So a role for the JAK-STAT pathway in lupus has also been recognized. So the JAKs are a family of cytoplasmic enzymes, tyrosine kinases associated with cytokine receptors on multiple types of immune cells. And these play crucial roles for resisting infection, maintaining immune tolerance, enforcing barrier functions, and as well as immune surveillance. So the engagement of interferon with the interferon receptor activates JAK1 and TYK2. This then leads to phosphorylation and activation of STAT1 and STAT2, which translocates to the nucleus to regulate gene expression. So new therapies are developed as we gain increased understanding of the aberrant pathways and mechanisms associated with active lupus. So this includes finding and identification of new B and T cell subsets that are altered in SLE in comparison to those in normal controls. And it's always important to remember that the inflammatory response pathways are highly redundant, and that targeting of a single molecule or single pathway may limit the efficacy of any single intervention. However, the goals of therapy continue to remain the same, and that's to decrease disease activity, prevent organ damage, improve patient outcomes, and ultimately to improve patient survival. So part of what we wanted to do in this section was to provide an overview of existing standard of care therapies and their limitations. So where are we now in terms of approved medications? And here you see the list. And there are 6 FDA-approved drugs. This is in the United States for use in lupus. The first 3, aspirin, hydroxychloroquine, and steroids, were grandfathered into the FDA for approval. This was before the 1960. And then there's a gap of over 50 years before approval specifically of a drug for lupus, and that was belimumab in 2011. And the dates for EMA authorization are in parentheses. And then anifrolumab in 2021. The indication for belimumab was expanded in 2020 for lupus nephritis, and voclosporin received FDA approval for lupus nephritis in 2021. But there are many other therapeutic options for treatment of lupus. As rheumatologists, as I like to say, have begged, borrowed, and stolen from other medical fields. And here's a more extensive list of some of the current therapies that we use for lupus with the FDA-approved drugs marked with an asterisk. So here you see the EULAR treatment guidelines for non-renal lupus. Updated ACR guidelines are not yet published, but are expected to be released in the near future. Per EULAR guidelines, and without delving too much into these specifics, unless contraindicated, all patients should receive hydroxychloroquine. Corticosteroids can be used, but exposure should be minimized to the greatest degree possible, with the goal of actually discontinuation or minimized to a dose of no greater than 5 milligrams a day. These guidelines also advocate for a treat-to-target approach with targets of remission or low disease activity states. It's also important to see and to note that the punishment should reflect the crime, and that the aggressiveness of therapy should be directed by the severity of disease activity. So DMARDs and biologics are recommended as second-line therapy for mild disease, and for first-line for moderate disease. Biologics are recommended right away for severe disease. But you'll see that only 3 biologics are present in these recommendations: belimumab and anifrolumab for mild, moderate, and first-line severe disease, and rituximab reserved for severe disease. So there clearly remains an unmet need for additional therapies for patients not responding to these currently available meds. And this slide summarizes the guidelines for lupus nephritis that were released at the last ACR in 2024 and should be published shortly. So these guidelines suggest that all patients receive hydroxychloroquine and RAS inhibition. So for individuals with class 3 or 4, with or without class 5, triple therapy is recommended as first-line therapy. And the preferred triple therapy consists of steroids, and this is defined as a glucocorticoid pulse, and then with the oral prednisone with a taper by 6 months to no more than 5 milligrams a day. So it's steroids plus mycophenolate plus either belimumab or a calcineurin inhibitor. Alternatively, steroids as defined plus low-dose cyclophosphamide plus belimumab could be considered. And if triple therapy isn't available or isn't tolerated, only then should dual therapy be considered. Recommendations for pure class 5 are similar, except that the preferred triple therapy is considered to be steroids, as defined for proliferative disease, mycophenolate, and a calcineurin inhibitor, with an alternative triple therapy of, steroids plus low-dose cyclophosphamide plus belimumab, or of the steroids plus mycophenolate plus belimumab. And similar to the proliferative disease recommendations, dual therapy should only be considered if triple therapy is either not available or not tolerated. So we've become more aggressive, or the guidelines are suggesting that we be more aggressive with use of triple therapy right off the bat. So there are several considerations when thinking about limitations of current standard of care therapy. Importantly, therapies are not perfect. They have imperfect efficacy. A medication frequently will work in some patients, but not are effective in all. Plus, response may not be complete. A medication may have a complete response in some, but an incomplete response in others. Also, not all medications will be equally effective in different disease subsets. And this is reflected. I mean, we know that guidelines for lupus nephritis are different than those in general lupus. Cutaneous features may not respond the same way to a given therapy as musculoskeletal features of disease. So lupus is a heterogeneous disease and not one size fits all. An additional issue that we all are aware of and that we see is loss of response. And with time, patients who initially respond to one medication lose their response. And so that, their meds need to be changed and a new medication needs to be administered. So patients often cycle through our menu of available meds. And during these episodes, when response is lost, to bring disease activity under control until the next medication can actually take effect, patients typically require exposure again to increased doses of corticosteroids. Finally, there are symptoms that may not be defined as inflammatory. So not all symptoms are going to be responding to the anti-inflammatory or immunosuppressive agents that we administer. And these type 2 symptoms, such as pain and fatigue, persist even when there's adequate control of inflammatory symptoms. So additional limitations of current standard of care additionally include safety concerns and accrual of damage. So immunosuppressive agents are associated with increased risks of infections, of cancer, of infertility, and we're all aware of the multiple numerous toxicities associated with corticosteroids, and these include infection, lipid abnormalities, which can contribute to the accelerated atherosclerosis that we know is present in lupus, cushingoid appearances, osteoporosis, osteonecrosis, and so that our current standard of care armamentarium is far from perfect. So in thinking about moving forward, we do need to go beyond our old school approach of global immunosuppression, and to think about a strategic use of targeted immunobiologic therapies based upon pathogenic mechanisms. But remembering that lupus is a heterogeneous disease and that mechanisms may actually not be identical in different patients and in different patient subsets. So briefly in summary, although patient outcomes have clearly improved, there remain unmet therapeutic needs, but with better understanding of the pathways and immune responses that are altered in lupus, New therapeutic targets are identified, which pave the way for novel treatments. So thank you. And I believe questions are
That-
going to be held to the end.
that's right. Yeah. Thank you very much. That's a brilliantly clear introduction to the subject and has made my job much easier as I now need to explain how we're going to target all of these things. So it's really good to have that background first. So, yes, I'm going to talk about some of the different treatment modalities that are in development with particular focus on one that will probably be new to many people and looks promising. So let's just hopefully slides will move. Here are my disclosures. So often when I start these talks, I show this figure, which is from this really nice review that you can find by Richard Aranow and his colleagues. It's published not even 2 years ago, but already it's becoming actually already starting to need updating because this is meant to be a summary of some of the different therapies that are being developed. And there's a few things to notice. Firstly, there's quite a lot of them. Their numbers are quite big when you look at things that are in kind of phase 1 studies and phase 2. There's really a lot of activity of different molecules here. As we get to phase 3, you get fewer of them because some of the trials don't work. And when you get through to marketed drugs, as you just heard, it's just been anifrolumab and belimumab until recently, although that is changing kind of as we speak, really. So, the other thing you notice is how many different mechanisms of action there are. And you've just heard about some of these pathways: complement, B cells, plasma cells, T cells, intracellular machinery, plasmacytoid dendritic cells, inhibiting cytokines. So this does create quite a complex landscape for us to understand as physicians. So I'm just going to go through just a few of the highlights, and this is necessarily brief because you could talk for an hour without running out of therapies to talk about. But let's start with what we should all know quite well, which is blocking BAFF. So belimumab's been around for a while. Most of us have used it in our clinics, sometimes quite extensively. And belimumab blocks this molecule here called BAFF, and BAFF binds to the BAFF receptor and is important in the survival of B cells. So blocking that is a way to target B cells. But one thing that's been recognized about BAFF is that it's actually part of quite a complex system. So as you can see on here, you've got 2 ligands, the BAFF and another one called APRIL. And these 2 ligands bind to 3 different receptors: the BAFF receptor, the TACI receptor, and the BCMA receptor. And as B cells go through their life cycle from the naive through to memory and plasmablast and plasma cells, they're moving between the amount of these receptors they express. So at the naive side, they're most expressing BAFF receptor, but once you get through to plasma cells, it's all about BCMA. So just targeting BAFF on its own might not be the best way to block this system. And some of the new therapies that are in development, the ones that are named there, called povetacicept, atacicept, and telitacicept, what they are, as the name suggests, is they're made out of this TACI receptor, which binds both BAFF and APRIL, in a soluble form. So if you give those drugs, you're blocking both of those molecules, and you should more comprehensively block the BAFF system. So there's a few different clinical trials that have been presented at conferences recently, quite a bit of experience with telitacicept, particularly in China, and some of the efficacy reported from those trials does seem quite promising. We don't really have that head-to-head against belimumab yet, but it does seem quite promising that this may be the next generation of BAFF blockade. Then there's B cell depletion, another molecule that I think many of us are quite familiar with. So here we're depleting B cells, but we're depleting a particular population of B cells. So B cells come from the bone marrow through these stem cell and progenitor stages. and then come out into the blood as an immature and then a mature, naive B cell, which goes around looking for its antigen. If it finds its antigen, then if it doesn't see its antigen, nothing more happens. But if it does see its antigen, it becomes activated. And then, as you heard just recently, it will then just it'll do things like go into a lymph node and get help from T cells in this B and T cell crosstalk. There may be ways that B cells can get activated outside of lymph nodes without T cells as well. And you'll get differentiation to memory B cells that retain that response and plasmablasts. Plasmablasts go around the blood for a few days. They don't live for very long in the blood, but if they can find their way into the bone marrow, they become a plasma cell that can live for months or years, or actually all your life, if you think of some of your childhood vaccines. So what rituximab does is it depletes on CD20. And the thing about CD20 that makes it such a great target in a way is it's not actually all B cells. It's this decision-making part of the B cell's life cycle that is depleted. So the stem cells in the bone marrow aren't depleted, and that means that B cells will always come back when you stop giving rituximab. And the plasma cells are not depleted, and that means that your protective immunity is preserved against your previous infections and vaccinations and things like that. You might say, well, that also means that some of the disease causing plasma cells might survive as well, of course, which is a relevant issue. One thing that we recognized early on with rituximab is that when you give this drug, what you often see in the blood is just plasmablasts on their own, still surviving. The naive and memory B cells disappear, but the plasmablasts on their own are surviving. And that's quite an informative fact because, like I said, they only live for a few days. So if a month after rituximab, you've still got plasma cells circulating in your blood, it means you must have some B cell activity going on somewhere else, like in the lymph nodes. And that's been exactly the rationale for some of the next generation B cell targeting treatments. This is what that looks like. So here's a flow cytometry plot with the naive B cells, the memory B cells, and the plasmablasts in purple. And after rituximab, you just see plasmablasts on their own. And people who have those plasmablasts on their own, which we called incomplete depletion, do not see the reduction in autoantibody titers in clinical response, whereas those with complete depletion do. So I think that what that tells us is that although rituximab didn't succeed in its trials, actually the logic of depleting B cells is quite good. And in some people, it did work well. So that brings you on to the next generation. So there is a next generation of monoclonal antibodies, of which obinutuzumab is another CD20. And it's what they call a type 2 CD20. Type 2 CD20s are not as dependent on NK cells and monocytes to kill B cells. They can kill them by themselves and they don't get internalized. So there's more potent B cell killing. Same target of CD20, just a better way of killing the B cells. And obinutuzumab recently reported positive phase 3 trial results in lupus nephritis, so we can expect to be using it in the future with a trial ongoing in non-renal lupus. There's also a molecule called ianalumab, which has the same advantages of the methods at which it kills B cells, but a different target. Because what ianalumab does, which is quite intriguing, is it has that same effective killing. So this type 2 can kill the B cells by itself, no less dependent on other cells to help do the cell killing. But instead of CD20, it's targeting the BAFF receptor. So it's a little bit like a combination of blocking BAFF and killing B cells with CD20 all in one, which is an interesting mechanism because actually it's probably the high amounts of BAFF that lead to the B cells coming back rapidly after drugs like rituximab and obinutuzumab. This molecule has been through phase 2 trials in lupus and is currently in phase 3. It also has quite a bit of data in Sjögren's syndrome. And then, as you heard, it's not all about B cells and T cells, lupus. There's also an innate immune component, which, well, you've seen a figure like this already once. So, type 1 interferons, which is this innate immune danger signal, um, that has multiple different types. There's many types of interferon alpha, there's interferon beta, epsilon, kappa, omega, all bind to the same receptor, the interferon alpha receptor, and signal through this JAK-STAT pathway. And what that does is it leads to very widespread activation of lots of different types of immune cells. So and it can explain many of the features of lupus. And also, as you heard, we always think about plasmacytoid dendritic cells as the source of type 1 interferons, but actually, they're not the only source. And this might be a really relevant fact to lupus. In fact, plasmacytoid dendritic cell function appears kind of reduced in lupus and before the onset of lupus. But what you have is production of interferons by all these other tissues. It's really as the ubiquitous immune signal because in the skin, the keratinocytes produce interferon kappa. I saw this. Michelle Kallenberg showed this. In the kidney, the tubular epithelial cells can produce interferon alpha. In the brain, the glial cells of the brains, like astrocytes and microglia, can produce interferon alpha and beta. In the synovium, the synovial fibroblasts can produce interferon beta. And even within the lympho-reticular endothelial system, local production of interferons could like subvert immune responses in different ways. So that's a reason why targeting innate immunity may have some unique effects that are separate from what you get from targeting B cells. Targeting B cells can't block everything that you see on this slide. And we have molecules that target the interferon pathway. The first attempts to do that were with these drugs called rontelizumab and cifalimumab, which were both monoclonal antibodies that target interferon alpha. But you can probably understand why that might not block all the different interferons and all the different tissue sources and things that we saw. And so anifrolumab is a more logical approach because it targets the interferon receptor and it's the same receptor for all those interferons. So blocking anifrolumab blocks the interferon signature better and leads to better clinical efficacy. And again, of course, this is a licensed drug that's now being explored in other indications and other contexts of lupus. Then what about blocking cell signaling? So type 1 interferons, as we said, signal through a JAK-STAT pathway. And they're actually, type 1 interferons are dependent on JAK1 and TYK2. TYK2 also blocks, also involved in the signaling of IL-12 and IL-23. This is the reason why it's been developed in seronegative spondyloarthropathies with deucravacitinib. And then the JAK inhibitors that we're quite familiar with from our treatment of rheumatoid arthritis might have a role here as well, because if you take a molecule like upadacitinib, then we're blocking JAK1, which is involved in type 1 interferon signaling, and also blocking some other inflammatory cytokines that may be important in lupus pathology, IL-6, IL-2, IL-4, etc. So these two molecules are both in phase 3 trials as well, and we'll be expecting to hear something about them in the next year or two. So now we come on to a mechanism of action that may be a little bit less familiar, which is blocking CD40 and CD40 ligand. So those of us who've been around for long enough will remember this the first time round because it came along with the whole field of co-stimulatory blockade. So as we've said a few times now today, what's important in autoimmunity, in most autoimmune diseases, is crosstalk. So B cells don't do what they do on their own. B cells do it by getting help from T cells. So and antigen T cells can't be activated on their own. They have to have antigen presented to them by an antigen presenting cell. And in both these types of interactions, where you've got this interaction between an APC and a T cell, or between a B cell and a T cell, you've got antigen presented in the context of MHC to the T cell receptor. But that on its own isn't enough to get an immune reaction. What these cells need to get an immune reaction is these co-stimulatory molecules. So you can see B7, which most of us know a bit better as CTLA4, CTLA4 interacting with CD28, or CD40 interacting with CD40 ligand. If those molecules aren't present, then the B cell and the T cell, or the antigen presenting cell and the T cell, can't talk to each other, and the immune response won't happen. So we know this quite well because of the existence of abatacept, which blocks one of these co-stimulatory pairs. And has been extremely useful, again, in many different immune complexes, and a very safe and effective drug that most of us have used. Now, at the same time that this was developed, there was also attempts to develop blockade of CD40 and CD40 ligand. There were some trials done. There was definitely some benefit in terms of the autoimmune disease under study, but there were also some problems that the early forms of this pathway blockade were associated with thrombosis events. So this is now being revisited because we now know how to block this pathway safely. The other thing we know now is that CD40 and CD40 ligand have even more effects than we first suspected. So there's a lot more going on here than just co-stimulatory blockade. So here are some of them summarized on this slide, and I'm not going to read everything out. But if you just look through this, you can see the review article if you want to look in more detail. But of course, we have our B and T cell crosstalk. Also, though, CD40 and CD40 ligand signaling has effects on dendritic cells and the antigen-presenting cells, which will alter the cytokines they produce and the CD8 T cell priming. It's also important for the production of plasma cells and autoantibodies. And CD40 ligand signaling has effects on the T cells themselves at the same time as the B cell, which means that you'll get different intracellular activation, different inflammatory cytokines being produced, different T cell polarization. And then we also have effects of CD40 ligand on the activation of monocytes and macrophages, and these are important sources of all the inflammatory cytokines. They're present in most of the organs that are inflamed in lupus, like in the kidney, playing important roles, and also an important source of type 1 interferon and the interferon signature. So you can see that as a target, this seems to hit many of the different immune pathways we've heard about. And the other intriguing thing about this is that the effects of CD40 ligand signaling go a bit beyond that blood immunity and into some of these tissue effects that I was alluding to when I talked about type 1 interferons. So taking the point of view of lupus nephritis, we think that CD40 ligand signaling has an effect on the mesangial cell proliferation and in production of profibrotic cytokines within the kidney, and has effects on the renal tubular epithelial cells that are an important source of some chemokines and things that are pulling in the immune cells from the blood. And this is just nephritis. CD40 ligand also has an effect on keratinocytes. So it has many very diverse effects. More recently, we found out actually that there's also binding of CD40 to this family of other molecules called integrins, which are involved in cell adhesion and have other functional effects on the cells. So this is a really diverse and complex system. So why is it now safe to block CD40 and CD40 ligand, or CD40 ligand rather? So this is what we think was the mechanism for the thrombosis, is that on any monoclonal antibody, you have a section called the FAB, the antigen binding section. That's what gives it its specificity for whatever it is, in this case, CD40 ligand. At the other end of the molecule, you've got the Fc gamma receptor. That's the part of the monoclonal antibody that allows it to engage in effector cells, like the effector cells I mentioned with respect to rituximab. Antibodies don't do that much on their own unless they're able to engage effector cells. And what platelets have on their surface is they have both CD40 ligand and they have Fc gamma receptors. So probably what happened is that if the monoclonal antibody could cause aggregation of the platelets. CD40 ligand also has some effects on platelet activation and endothelial cell function, but those wouldn't be so negative. So this gives us a pathway to block this system because we already have an antibody construct from other health conditions that can solve this, which is called pegylation. So antibodies like rituximab are chimeric, meaning that they have mouse parts of protein in them and human parts. Most monoclonal antibodies we use these days are humanized or fully human, meaning that all these parts are taken from human protein templates. Pegylated antibodies are ones where the Fc region is removed and instead it's replaced with something called polyethylene glycol, which is a synthetic molecule, which can have several effects. Obviously, it mutes the Fc, so you no longer have an Fc region that can bind to the Fc gamma receptor, but also it can it can affect the pharmacokinetics of the drug. Keeping it in the circulation for longer, for example, or stopping placental transfer. So we have one of these now to block CD40 ligand, which is dapirolizumab pegol. And we have a phase 3 trial that was reported last year at ACR as a late-breaking abstract. So this has got a very apt name. It's called Phoenix Go because it's like this line of therapy coming from the ashes. So in Phoenix Go, it's a phase 3 randomized controlled trial, similar to most phase 3 trials that you're going to hear about in more detail soon. But what happens in Phoenix Go, patients are enrolled if they have moderate to severe disease activity, defined by 2 BILAG Bs or 1 BILAG A and a SLEDAI-2K of more than 6, and then randomized 2-to-1 to either dapirolizumab, which is given IV every month with standard of care, or placebo with standard of care, and then a mandatory steroid taper. If patients want over 7.5, they had to try to taper to get under that, and a primary endpoint of BICLA response at week 48, and some secondaries that I'll show you. These are the baseline characteristics. They're fairly typical, again, for a lupus trial. So the majority of patients were female. The mean age was about 42. Time since diagnosis, about 10 years. About 70% of the patients had a SLEDAI score of 10 or more. A substantial proportion of them were positive for double-stranded DNA antibodies or had low levels of C3 or C4, so that kind of serological activity that can sometimes indicate more severe disease or higher responses. Quite a lot of the patients had antiphospholipid antibodies or lupus anticoagulants. And most of the patients were on antimalarials, most of the patients were on steroids, about 60 to 65% were on immunosuppressants, and half of the patients had a steroid dose that was greater than 7.5, so therefore had to mandatorily try to taper it. Here's the primary endpoint on the left here, which is the BICLA response, which you can see was met by 34.6% of patients on placebo and 49.5% of patients on dapirolizumab. So that's a highly significant difference of about 15 percentage points. And then on the right, you see the SRI-4 response, which is the alternative primary endpoint that's been used in some other clinical trials. And for that, this treatment difference was more like 19%, and again, highly significant. Nominal significance in this case. When we look at the lupus trials, we don't just look at patients getting better, we also have to check for patients getting worse. So, in other words, you look for severe flares. In this case, you want a low value. As you can see, severe flares in the patients who are on placebo, although some of the patients in placebo responded, 23% of them had a severe flare. That's compared to only 11.6% of the patients on dapirolizumab having a severe flare. And then I'm just going to show these slides in the opposite order. If you look at the SLE-I2K over time, you can see this kind of gradual improvement. So not too much at 4 weeks or at 8 weeks or at 12 weeks, starting to get some separation of the treatment groups at 16 weeks and getting bigger by 20. 24 was actually defined as a secondary, which were actually, as it happens, those were a bit close together. But as the trial went on, the treatment groups get further apart. So that makes it seem like a fairly gradual increase in efficacy. But when you look at the steroid tapering, you see a little bit of a different story, because if you look here, you can see that the steroid tapering was the proportions of patients who had been able to taper steroids was already different between the two treatment groups as early as week 8. So that may be one reason why it took a bit longer to see differences in disease activity, because you've got steroids coming down at the same time faster in the treatment group because they're doing better. What about safety? So the all-important question, right? So this here you see a feature that is quite common in lupus trials. Because if you look at all treatment emergent adverse events, just take serious treatment emergent adverse events, is actually higher on placebo than it is on the active group. We see this often in lupus trials. 15% of placebo-treated patients had a serious treatment adverse event versus only 10% of the patients who were on the active arm of dapirolizumab. And then if you look at the infections, you see something quite similar. 3.7% for severe infections on placebo compared to 1.4 on DAPI, 5.6% of patients on placebo compared to only 3.8 on DAPI. I just believe this is because the patients who were on the active group were generally healthier, were lowering their steroids more, and their immune system was becoming more normalized. There's a slightly complex signal with these herpes viral infections, and I think it'll be useful when we have the next trial, because you can see that the overall numbers favored DAPI, as did the total herpes zoster infections, but there were 2 cases of ophthalmic herpes zoster and 3 cases of ophthalmic herpes zoster, all occurring in DAPI. I don't know why that is, because the overall herpes infections went the other way, and I think it may just be a strange cluster of events. So there's another phase 3 in progress that should give us a bit more data on that. When you look at the thrombosis, really nothing. One event occurred. That's it. No signal between the two arms. Okay, so that's Phoenix Go. That was a phase 3 clinical trial. It's met its primary endpoint in moderate to severe SLE. There is another one in progress. So you need 2 phase 3 trials to license a drug. This one's called Phoenix Fly. It's a similar trial and it's currently open to recruitment. So you can find some of the details about that on clinicaltrials.gov. This is a global study. It's enrolling 450 patients. So there may be sites who are enrolling patients in your region that you may want to consider referring patients for. It's always nice to be referring patients into a trial where you already have some indication that the drug is likely to be a useful one. And then just to finish up, how does this compare with other lupus treatments? So this is quite a difficult question to answer, because we don't have extensive experience on all these treatments and comparisons, but there are some comments I would make. So here I've just chosen a few of the ones that we've already talked about today and some of the related ones that we didn't have time to talk about. So belimumab targets BAFF. That affects B-cell survival. We've already got existing licenses in non-renal lupus and lupus nephritis. There's some future populations being studied, other diseases, earlier phase of lupus. We also have some related therapies there. Telitacicept, ianalumab has some anti-BAFF effects. Then we've got obinutuzumab. It targets CD20 B cells again, but this time B cell depletion. We've got a phase 3 trial in lupus nephritis. There's one expected, I think, later this year for non-renal lupus. We've got some related therapies here, ianalumab again, and rituximab existing. There's also the CAR-Ts and BiTEs we haven't had time to talk about. And then we can change gear a bit and target innate immunity with anifrolumab, targets the interferon alpha receptor. This has effects not just on blood, but on the innate functions in other target organs, which is different from the B cell therapies. We've got an existing license in non-renal lupus. There are a number of other trials going on in things like cutaneous lupus, dermatomyositis, lupus nephritis, scleroderma. There's also another molecule called litifilimab that targets plasmacytodendritic cells with the aim, again, of blocking type 1 interferon. Then we've got voclosporin. This is a calcineurin inhibitor. It targets T cell function, which works on podocyte, so that's an immune suppressant effect. It has a secondary effect on podocyte stability. So it's really suited for lupus nephritis rather than other forms of lupus, similar to another drug, tacrolimus. Deucravacitinib, the TYK2 inhibitor, blocks interferon signaling as well as some other cytokines. Upadacitinib blocks JAK1 signaling, which works on interferon and another set of cytokines. And these are both in trials in non-renal SLE, and there are some others. So how does DAPI compare to those? Well, it's a completely different target, CD40 ligand. As I've shown you, this target probably has the most diverse effects of all the targets we've talked about. B and T cell crosstalk, dendritic cell effects, T effects, cell effects, myeloid activation, and some effects on some of the other tissues involved in lupus, which is an intriguing property. We are currently at an earlier phase of development, so we have a positive phase 3 trial in non-renal SLE. There's a second phase 3 trial in progress. There's one other molecule of that. Well, there's been a few others, but there's one other that I think we've seen more data on, which is a drug called iscalimab. But dapirolizumab is the one that's most advanced. So I think this is something really, when we get to the Q&A, for us to discuss as to how we think this is going to pan out over time. Because at this moment, no one exactly knows, but you can understand why there would be a difference between these things. Okay, so like I say, immunology is complex. Getting the right target for every patient can be a bit of a challenge. You've heard about some of the most promising current approaches, B cells and innate immune targets, and you've heard about why CD40 ligand is somewhat unique and that we have positive phase 3 data. And with that, I think I better hand on to the next presentation where you can understand a little bit more about how these trials really work. So it's my great pleasure to introduce Professor Richard Furie. You really couldn't have asked for anyone better to tell you about clinical trials and outcome measures and what's needed to make a positive trial. So over to you, Rich.
All right, thanks, Ed. So we heard all about the pathobiology of lupus. So the real question is, if we understand it so well, why don't we have more drugs out there? So that's what I'll address in the next 20 minutes. Here we go. All right, disclosures. And this is what I'll talk about, starting with the complexity of clinical trial design. So you would think studying lupus would be pretty easy because there are just two types of study populations. You have SLE and lupus nephritis. And within SLE, we can study single organ domains like skin or joints, or we can do the whole works. So let's start out with single domains. And as you probably know, most patients who come into our lupus clinical trials come in because they have active rash or they have active arthritis, or in a lot of cases, both. And you would think studying a single domain, such as studying just skin or studying just joints, would be simple. It's a more homogeneous population. Well, not exactly. So for cutaneous lupus, as you well know, we have acute, subacute, and chronic cutaneous lupus. And I think we have it down pretty well how to study cutaneous lupus. But arthritis is far more challenging. There are different types of arthritis. You have the classic so-called non-erosive arthritis, though we know it is erosive. And then you have Jacques, and I don't think Jacques responds to any intervention. And then, of course, there is a lupus, the overlap of rheumatoid arthritis and lupus. That is someone who clinically looks like RA, but has the serologies of a lupus patient. So in designing a trial to study just a single domain, such as skin or joints, you need specific entry criteria and specific endpoints. And there is the CLASI, and you can see what the abbreviation stands for on the slide, for skin disease. And we just had a breakthrough in that the FDA has accepted CLASI as an endpoint, specifically a 70% reduction in the CLASI activity score. With joints are our nemesis in lupus clinical trials, because we can do joint scores just like in rheumatoid arthritis, based upon tenderness and swelling. But the problem is that the arthritis of lupus is far more subtle than in rheumatoid arthritis. So we're still trying to figure that out. All right, so the alternative to studying a single domain would be to study all of lupus, multi-organ domains. And that's appealing because it basically mimics the real world lupus patient, coming in with a variety of different manifestations. But if you do that kind of design, then you're relying on SLE scores or BILAG scores for entry and for endpoints. And we have a lot of idiosyncrasies with these outcome measures. Now, more recently, we've incorporated the SLEDAI and the BILAG into the SRI and BICLA. These are dichotomous outcome measures. And because they're dichotomous, it is appealing to say someone is a responder or they're not. But you inherit all the idiosyncrasies of the SLEDAI and BILAG because the SRI and BICLA are, in fact, dependent upon those specific metrics. And a good example would be the TULIP-1 study that was anifrolumab in phase 3, where we saw discordant SRI and BICLA results. All right, so if we're not studying SLE, we can study lupus nephritis. And again, you might be fooled into thinking that lupus nephritis is very homogeneous. Well, not exactly, because there's great variability in those with proliferative disease in their activity indices and their chronicity indices. And so there may be differential responses, especially when we're relying on a reduction in proteinuria. And proteinuria can either be generated because of active lupus or because of damage, or in many situations, both. And patients who come into our lupus nephritis trials, besides having a biopsy showing active disease, have to have a certain amount of proteinuria, usually greater than a gram, though sometimes 1.5 grams. But some patients come in with a lot of proteinuria, 5, 6, or even higher grams of proteinuria. And so it may be that those with very high levels of proteinuria take more time to reduce their proteinuria down to a threshold that would classify them as a responder. And then we have class 5. I must say in clinical practice, class 5 is my nemesis. But where there have been a few studies that have incorporated pure class 5, and I think that's a certainly different histology with different responses perhaps to our medicines. All right, then the other thing to address is, what do you want to study? Do you want to study active disease or do you want to study flare prevention? So nearly all the studies that we've done in SLE have enrolled patients with active disease. In fact, high disease activity. And you just heard about some studies, SLEDAI 6, BILAG-A, or 2Bs. It's getting harder and harder to find patients with true, and I emphasize the word true high disease activity. Some of the items on the SLEDAI are very subjective: alopecia, rash, and oral ulcers. So we have to be careful that we don't contaminate our studies with patients who may generate very high placebo response rates, since those items may not be related to active lupus. The alternative to studying patients with active disease would be to do flare prevention. The problem there is that you're held hostage to the flare rate. You need a lot of patients, And these are generally long and expensive studies. All right, now let's turn to outcome measures. The outcome measures that have risen to the top are the composite indices that I mentioned, the SRI and the BICLA. They're accepted by regulators. But we're hearing more and more about lupus low disease activity state, so-called LLDOS, as well as the DARIS, definition of remission in SLE. And I could spend an hour talking about all of those and the genesis of these dichotomous responder indices, but we don't have the time. But let me just sum it up with this one slide. So there's a big difference between SRI and BICLA versus the lupus low disease activity and DARIS. And it's basically, I think it's summed up very nicely in that phrase. It's good to be better, but it's better to be good. I don't know who to credit that to. But what we're talking about is a reduction in disease activity versus the attainment of a state. So for example, SRI is driven by a 4-point reduction in the SLEDI. Now you could start out with, say, 16 points on your SLEDI, and you get down to 12. So you might be an SRI responder, but you still have a lot of disease activity. So that's getting better, but it's better to be good. And on the right-hand side, you see some of the characteristics of LLDOS and DORIS. So these describe a state of being. So it's an absolute versus relative. And there's no question the LLDOS and DORIS are easier to complete. They're not accepted by regulators as a primary endpoint just yet. They are certainly more stringent, so we do see lower response rates. But what's been shown repeatedly with those two metrics is a correlation with a lot of benefit. So I just have correlates with less damage, but there's a whole slew of benefits seen when you achieve that particular state of LLDOS or DARIS remission. All right, so why don't we have more drugs? Why are clinical trials failing left and right, though we are getting better? And I've been involved with these since the get-go from the 1990s, and it was failure after failure after failure, very frustrating. All right, so these are some of the barriers to success. Starting with recruitment kinetics. I mean, recruitment never goes quickly enough. So why is that? I just think there are fewer patients with high disease activity. And why is that? Well, I think there's greater use of mycophenolate for extrarenal disease. And I think word is finally getting through that we should have every lupus patient on hydroxychloroquine, and hydroxychloroquine works. And then obviously there are approved drugs. You've heard about some of them. But I think there's also greater use of approved drugs that are off-label for lupus. Examples, obinutuzumab for lupus nephritis. That drug has been approved since 2013. And then some of the JAK inhibitors approved for rheumatoid arthritis that we will use off-label. So I know in my practice, there are fewer patients walking through the door with high disease activity than probably 10 to 20 years ago. All right, let's just talk about enrollment of diverse populations. Big push to enroll diverse patients, especially patients of African ancestry, and not easily done. So for example, I show you some data for the TULIP-1 and TULIP-2 studies. These are global studies. About 13% of the cohort was of African ancestry. Now, if you focus just on I call it a regional study, this was belimumab phase 2, largely recruited in North America. The patients of African ancestry constituted about 25% of the population. Now, in the US, it's a little over 30% of our SLE patients are Black. So there's no question that Black patients are underrepresented in our clinical trials. We've made attempts to boost those numbers, easier said than done. And so, a lot of this is about looking at subgroup analyses. We want to know, whether the drug works in the various subgroups. But you have to remember, when you look at those forest plots that are always included in our trials, sometimes in the supplementary material, that these subgroup analyses are way underpowered. All right, the nemesis of all lupus clinical trials. Here's a riddle for you. It starts with a P and it ends with an O. Placebo. And though I never took Latin, I understand placebo is Latin for I shall please. This is a big problem for our lupus trials, especially the SLE trials. And here's a table showing some of the drugs that we've studied over the last 15 years. They're listed on the left, and then down the center is the endpoint. But what I have on the far right is the placebo response. And you have to remember, in all our trials, whether it's SLE or lupus nephritis, placebo is not just placebo. Placebo added to standard of care. Now, you could argue that the background standard of care, and remember, patients are allowed to come in on steroids, they're allowed to come in on immunosuppressives, they're allowed to come in on antimalarials. But you never know whether it's optimized standard of care. But be that as it may, you see placebo response rates. What's the highest one on this list? It's about 45%. Well, if your comparator is achieving the desired response at a rate of 45%, you better have a very good drug to be able to show statistical significance. We need to lower the placebo rate. So how can we do that? Well, we can enroll very active patients. And I'm not talking about someone with a little alopecia. I'm not talking about the person with an oral ulcer, which might be a canker sore. We're talking about truly active manifestations of lupus. And here's an example. So this was the EMBRACE trial. This was a post-marketing study mandated by the FDA to study belimumab in African Americans. And it's a forest plot, and I'll just run through it very quickly. So here you see the baseline results. It did not achieve the desired endpoint. But if you start looking at baseline characteristics, and I'm going to run through different items basically that are associated with more active disease. So for example, you see a SLE score of 10 or greater, and on the forest plot, the point estimate moves to the right compared to a SLE score of 9 or lower. And then we have DNA antibodies, positive versus negative. And you see those with positive baseline DNA antibodies, the point estimate moves to the right in favor of effective effects of belimumab. And then looking at complements, and you see the same pattern, a shift to the right in those that had a low C3 or low C4. And you can add the complement to the DNA and you see the same type of result. So we need to enroll active patients, else you're going to have a high placebo response rate. Now we could enrich the cohort with a biomarker. And speaking of dapirolizumab, and I've been involved with dapirolizumab since the 1990s, but this was a post hoc analysis of the phase 2 dapirolizumab study that was done a few years back. And that was to establish certain characteristics that might predict a high placebo response rate. So normally when we look at graphs, we're looking at response rates, and we are here, but we're looking at the placebo response rate. So on the far left, you see the disease course, and we stratified into those with an acute flare versus those who had just kind of ongoing grumbling activity. And the reason for doing this, if you have someone who has an acute flare, I don't care, pericarditis, pleuritis, or for that matter, arthritis, it may be gone spontaneously or with a little help from some medicines. But the point is that it's not a sustained problem. So here you see the graph on the far left, maybe a little hard to distinguish the colors. And you see a much lower placebo response rate in those who had persistent disease activity as opposed to those who had an acute flare. Move to the middle column, middle display, and you see the value of a low complement. And if you had low complement at baseline, you tended to have a much lower placebo response rate. And so this was used as entry criteria in the phase 3 study with dapirolizumab. And then if you combine those two graphs on the left, you see the one on the right showing that a combination of acute flare with a low complement gives you a much lower placebo response rate than the other group, 24% versus 80%. So we have to think about this in our design. Now we could withdraw background therapy at baseline, kind of a sink or swim approach. And a lot of our studies now, we have aggressive withdrawal of steroids. There have been some designs where you just stop steroids at baseline or stop immunosuppressives at baseline. But the problem is it's really stacking the deck, because I'm not sure you can then call it standard of care if you stop everybody's background therapy. So we have to reach, some kind of happy medium there. All right, another approach, weed out the placebo responders early on. And there have been a couple of trials with run-in periods, and these were done in lupus nephritis. We did a study several years ago with anti-tweak in lupus nephritis, where all the patients were treated with mycophenolate for the first 3 months. And those who did not achieve a certain reduction in proteinuria would then go on to randomization. But those who did achieve a reduction in proteinuria to less than 1 gram were no longer allowed to participate in the study. So we were weeding out placebo responders early on. Deucravacitinib did a similar study in lupus nephritis, though they did not complete that study. They had difficulties with enrollment. And then lastly, adopt more rigorous endpoints. And I just give you an example of Bliss 76, so we're going back in time a lot of years. The endpoint was the SRI-4, meaning a 4-point reduction in SLE was the driver of efficacy. And just keep an eye on the placebo column in the middle. As you crank up the metric, that is an SRI-5, which means a 5-point reduction in SLE to be a responder, you see the placebo response rate goes down, though so does the response to belimumab. So you may be sacrificing response rates, but you may be gaining discrimination between placebo and belimumab. So tougher endpoints may yield greater discrimination, though of course, lower response rates. And here's another good example. This was the phase 2 anifrolumab study called MUSE. The primary endpoint included not only an SRI-4, but also lowering the prednisone. And though the MUSE primary endpoint was actually at 6 months, I'm showing you 1-year data. So if you exclude the taper to be a responder and just rely on SRI-4, you see the placebo response rate was 40%. But if you require steroid taper, the placebo response rate drops down to 25%. Now you do see a reduction in the response to anifrolumab, but there's a greater amount of discrimination if you have that composite endpoint of SRI-4 and prednisone taper. So I'm a big fan of including prednisone taper in the response rate. All right, so there's no question studying SLE and lupus nephritis have been incredibly challenging. I'm not sure there's a disease that's as challenging, but we've made progress and we've witnessed 3 drug approvals for 4 indications. And I think we'll see another one maybe later this year in the form of obinutuzumab. And so we still have a ways to go to refine our trial design. Investigator education is key to understand the SLE, to understand the BILAG, to understand who should be in a study and who should not be. And we will probably see outcome measures, new outcome measures in the very near future. So this will all translate no doubt, into better outcomes for our patients with lupus. And I thank you.
Thank you very much. Again, as always, extremely clear and informative in helping to understand what these trial data mean, I guess, and how to look at them. Um, so we now have time for a few questions. There's some questions come in the chat that are covering quite a lot of different subjects. So I'm going to try and sort of summarize them, I guess. So the first one, I think this could be one for you, Cindy. This is an interesting one. Is we didn't talk about CAR T therapy, and do we need all these mechanisms of action if we can get drug-free remission with CAR T B cell depletion? Oh, you're muted still, by the way. You're muted, Cindy.
Oh, okay. You can hear me now?
Yeah, yeah,
Okay. So, CAR T therapy is, I'm going to say, the newest kid on the block. Um, the initial studies that have been published are incredibly exciting, and the responses seem incredible and remarkable. I don't want to say too good to be true, but what I think is really important to remember is the heterogeneity of lupus, and that not all lupus is the same. So the numbers are still small. And what I think that the results of the CAR T therapies tell us is that B cell depletion and profound B cell depletion works for many, many patients. But I think that with time and with exposure of more patients to this type of cellular approach, that not everyone is going to respond, and it's going to remain for us to be able to best identify the patients that are going to respond to CAR T therapy, that those whose disease is driven by B cells.
yeah. I agree. That's my feeling as well. The pathology is too complex to say that one target on one cell will treat everyone in every way. Yeah, yeah. And then another one, again, this is kind of summarizing a few different points. Rich, I think this is that like here, and also same as when I present, people always ask about like certain types of interesting patient. What about my patient with neuropsychiatric, or what about my patient who's got lung involvement? Can I use this new drug for them? Do we know, Rich, from the trials?
We do not know. As I mentioned, so about 80% of the patients come in with arthritis and or rash.
Yeah.
So we certainly know about that. And if you look at the other domains, they're not well represented. And some are actually excluded, like neuropsychiatric lupus. So that's the next frontier.
So we have to find some way of doing trials that addresses some of this stuff. Yeah. Or learn from real world evidence is the other thing, of course. When you look at treatment guidelines, what you often see is when you get into those more niche indications or severe types of patients, like the ones you mentioned, actually people say, well, there's most experience with rituximab, because even though it's open label, but people have been using it, playing with it, trying it.
So Ed, it's
And then
also
another one, actually, probably best for you to ask to you is,
Ed, Ed,
sorry,
it's also really important to remember, particularly for neuropsychiatric lupus, is that if we're thinking about treating, we need to be thinking about drugs that are going to get into the brain. And the blood-brain barrier is a formidable, is formidable.
yeah.
And not everything is going to get through the blood-brain barrier, and which will exclude or is designed to exclude antibodies.
Yeah. And actually, another point just made me think of there is that we often see patients who have neuropsychiatric lupus with a normal MR. And that always makes me think, are we sure that the drugs that we use to target all the rest of lupus are going to work there? There is the pathology going on inside the brain at a slightly different level rather than being full of inflammatory cells, isn't it? Which is another complexity. Yeah. So maybe a different class of therapies might be needed. Um, And then maybe we've just got one time for one more that I hope will be quick, which I think is one that I think Rich would be able to answer. What about complement inhibitors for lupus?
Yeah, so the story with complement goes back to the 1990s. I heard a talk by the complementologist at Alexion, and he showed the NZB, NZW mouse model, and their complement inhibitor worked great. I said, all right, we need to do a study in humans. So we used eculizumab. I guess we were probably the first, and administered it to lupus patients in a phase 1 study. And then we were abandoned in lupus, though in more recent years, there have been other companies with complement inhibitors. In fact, Alexion is doing a study with ravulizumab, that's sort of their long-acting eculizumab, in lupus nephritis. And now complement is a hot area, and I think it's just a matter of time before we see some results of studies with complement inhibition. But it certainly makes sense.
Yeah, exactly. It does make sense. So we're going to have even more modes of action than we've just talked about. So, unfortunately, there isn't much time for any more questions. So, really, it's just time for me to thank our speakers. Those were brilliant presentations. And thank you for your insights. And also, thank you to everyone online at home for watching. I hope you've enjoyed this. Thank you for participating. These, as like all the other Lupus Forum activity, this will be available online to watch at a later date or to send to your colleagues. And there'll be lots more coming up from us in future. So you can sign up to receive our updates through email. Thank you to our sponsors who supported this activity. And just one last thing before we sign off is that there is a feedback survey that's going to come up. So please do give us your evaluation, let us know your feedback. We really do look at it to decide what content we're going to offer in future. So we'll definitely take into account any suggestions that are made. So thanks everyone, and goodbye.